So again, I've tried to stay in my lane a little bit with this talk because atrial and ventricular septal defects can be part of very complex cardiac lesions. And with the exception of a couple mentions for that, I'm going to try and really restrict myself to the isolated forms of these, obviously involving some embryology and a couple tricks and views that I think work best for me. I have no different disclosures now than I did an hour ago. So starting with atrial septal defects, I feel like this is the one embryologically that gives people a little bit of grief, just kind of understanding the formation and really knowing that the components fuse early in fetal life and look very differently as a fetus than you would expect postnatally. And that's really because that intra-atrial communication is essentially an obligatory part of fetal circulation. Except for a PFO, or patent foramen ovale, any residual communication across the atrial septum is considered abnormal or an ASD afterwards. But we're looking at that as part of our normal circulation when we're evaluating fetuses for echocardiography. There are 4 subtypes, understanding that the most common ones are going to be secundum ASDs, and I have a cute little video to show you in just a second. The primum ASD really comes into that component of an AV septal defect, and I only touch on this briefly other than to leave it to my colleagues who are talking about AVSDs. Sinus venosus and coronary sinus ASDs. I have one picture that I actually borrowed from Alfred a few years ago. I've never made this diagnosis prenatally. I'm sure I'm in pretty good company with a lot of other people who have not, but we're just going to touch on it quickly. So atrial septation happens very, very early in pregnancy from the 4th to 8th week. The septum primum grows from the roof of the atria towards the endocardial cushions, or AV valves. And then there's this sequential closure of the ostium primum, which fuses with the endocardial cushions, creation of a new communication or hole by apoptosis, and subsequent formation of the septum secundum. By the 8th week of life, what you're left with is fetal circulation in the form of a foramen ovale flap. And this is actually, I think this looks like a turkey, but it's a really good septation. It's boosted from Embryon animation. I at least credited them. So here is our early heart in the probably 6th or 7th week of gestation. We're going to rotate this and then kind of take a little bit of a guillotine towards the right atrium. And you can see we have growth of the septum primum towards the endocardial cushions. We then start to see apoptosis and the foramen secundum form, with the septum secundum again growing towards the AV valves, creating the foramen ovale. This creates the right to left communication across the atrial septum as the foramen ovale. Now, the atrial septum development occurs, as we said, septum primum and secundum. There's a separate portion of the primordial septum called the sinus venosus that splits into right and left horns. The right horn, which is larger, creates the inflow of the IVC and SVC into the right atrium. The left horn fuses with the septum primum, creates opening of the coronary sinus, which is down here. These I'm going to touch on really briefly because they're very, very hard to pick up. So how are these formed? The secundum ASD, which is the most common one you're going to see, is really excessive resorption of the septum primum during apoptosis. So those holes that formed created an excessively large hole, and the defect can occur anywhere along the septum primum, but typically adjacent to or in the region of the foramen ovale. The sinus venosus ASD really is incomplete inclusion of the right horn of the sinus venosus into the right atrium, very commonly associated with anomalous insertion of the right superior pulmonary vein. It's a rare diagnosis prenatally. It's one of those ones that I'm mentioning this really for the purpose of, if you don't know it exists, you're never in your wildest dreams going to pick it up. There is, nobody doing ultrasound is new to this dictum, but really keep in mind the eye sees what the mind knows. So I'm mentioning it, floating it out there, so you know that if there's ever something in that vicinity you can't quite pin down, say, somebody once mentioned A, and you might get it. The coronary sinus ASD is located at the site of where the coronary sinus ostium enters into the right atrium, returning the coronary artery blood flow, coronary blood flow to the heart, and is again one of those ones that can be really tricky to pick up prenatally. So here's a schematic of looking into your right atrium. The common ones we're going to see are the secundum ASD, kind of middle of the road, excessive apoptosis or cellular reabsorption. Here's the same idea, secundum ASD, but with posterior septal involvement. Sinus venosus would be superior and inferior, and coronary sinus ASD is down here. The primum ASD, like we talked about, is really part of that whole AV septal defect complex. And short of a couple pictures, I'm going to leave that to one of my colleagues to mention. So again, getting back to basics, you pick things up by being really familiar with normal anatomy. So normal atrium septal primum, normal foramen ovale flap, which in most instances goes not quite halfway across the left atrium, septum secundum. Now, how many people always look at the ventricular septum but really don't pay a whole lot of attention to the atrial septum? You wouldn't be alone. That's really generally the way most people are trained to look. So again, remember that interatrial communication, foramen ovale patency, is part of normal fetal circulation. So how do you distinguish between something that's there normally and something that's pathologically there and may not close postnatally? There's really not a lot you can hang your hat on, with the exception of large defects or maybe the absence of bowing of the foramen ovale flap into the left atrium with a large deficiency. And those might raise your suspicion for a secundum ASD. But again, you have to wait for the normal interatrial communication to close as part of neonatal life to be certain with this. The postnatal incidence is not small, about 7% of CHD, which highlights the difficulty of making this diagnosis prenatally because that's obligatorily one of the normal fetal shunts. The prenatal detection of the sinus venosus or coronary ASDs is rare, and I'm really not sure how many are documented in the literature, but none by me. Generally, these are not considered heritable with the exception of the association with Holt-Oram. It is the most common cardiac defect within that Holt-Oram spectrum, again, raising the difficulty of making that diagnosis prenatally if you have a very, very mildly affected proband. So if you think about an affected parent and maybe the only thing the fetus has is an ASD and an abnormal carpal bone, you can appreciate how difficult that is to make prenatally. Remember why the interatrial communication is important. The second shunt is the patent foramen ovale in the fetus, and that is there for the purpose of deliberate direction of hyperoxygenated or highly oxygenated blood that's coming back from the ductus venosus. So venous return to the right atrium comes in two different varieties, right? We have flow coming back through the IVC, which comes into the right atrium and then actually gets preferentially directed through the tricuspid valve. But this highly oxygenated blood, which is flow accelerated by the ductus venosus, comes back through the heart, through the foramen ovale, and then goes up to the systemic circulation. So that shunt is there for a purpose, and the purpose is to deliver high velocity, highly oxygenated stream to the left atrium. So knowing this, you realize that an ASD is really of no hemodynamic consequence to a fetus, which again makes difficulty picking it up because you don't really have any downstream flow abnormalities that you're going to be looking for. As we said, in general, these are really difficult to pick up except for the primum ASDs that are part of the AV spectrum. And that is a deficiency of, remember we had our primum septum here, our foramen ovale, and then our septum secundum. So you can see here we have just kind of this linear insertion of the AV valves, but like up view from the right atrium. And oftentimes you'll see this little floating white dot in the atrium, which is that untethered or unconnected part of your atrial septum. Here's a complete AVSD. It's a tile tomographic image. Here you can see the floating little white dot, the foramen ovale, the septum secundum, and this defect right over here is our primum ASD. Here's another one where we have two discrete AV valves, but again, you can see they kind of come across like a crescent or linear insertion, septum primum defect over here. First pitfall I'm going to mention to you is one that I always used to love when I went to meetings and people taught me, like the aha moment of not to mistake something for something. Does this look like an atrial septal defect to anybody? It's okay to say yes. So first clue that it's not is we see a tricuspid valve opening and closing well. Notice how we're not seeing the mitral valve opening and closing well. And the reason for that is not that it isn't opening and closing well, it's that we are beneath it. What structure would we be in if we're beneath it? Well, we're in a dilated coronary sinus. And you get a dilated coronary sinus through a couple ways, but most typically when you have a left superior vena cava that drains to the heart and then tunnels below the heart, and I have a good picture to explain that, returning blood from the upper body to the right atrium as a dilated coronary sinus below the heart. And that's what happens. Here's your LSVC, drains below the atrium into the right atrium. So imaging through here gives you the appearance of an ASD because there is no septation to a dilated coronary sinus. You just have to realize you're beneath the atria and not in it. Well, how do you do that? First and foremost, like we said, is watch for the mitral valve opening and closing. If you're not seeing that, it's a good bet that you're below the mitral valve and in the dilated coronary sinus over here. The second is pay attention to direction of flow. What direction does flow usually travel through the atrial septum? Or it's from right to left, right? Well, dilated coronary sinus blood is returning from the left side to the right atrium. So here we have blood flowing from left to right. It's coronary sinus drainage and not flow from right to left atria. And then the extreme example would be essentially a common atrium. This is a fetus who has multiple other structural abnormalities, but not only do we have a primum defect, we have a secundum defect, we have no foramen ovale, so really common atrial structure. The sinus venosus, like I said, is very difficult to detect prenatally and can be even postnatally just based on looking at the arrangement of the pulmonary veins and the SVC. Essentially, the only way that it's been ever explained to me that it can be picked up is the sense of like an overriding SVC, where the SVC overrides the interatrial septum with displacement of the right upper pulmonary vein. This is an image shared with me by Alfred. You can see here's our interatrial septum. We have basically an overriding SVC. So here's our sinus venosus SVC, and here's a right pulmonary artery. So I have not made this diagnosis prenatally. I feel like of all the things I'm happy to miss, I suspect this one will be one that I miss regularly. And it's just nuancy and it's hard, but at least now you know it exists. And if you're ever faced with this image, maybe consider it. Finally, a variant of normal that you might see as far as atrial septation, which is an aneurysmal foramen ovale or redundant septum primum flap. Like I mentioned a couple minutes ago, normally you see this flap go about halfway across the left atrium. Here you can see the excursion is quite a bit further, almost to the far wall. This can, if you Doppler it or add color flow to it, actually be a little bit of impediment to inflow into the mitral valve and can cause some left-sided changes to the heart. Notably, this is also one that's associated a lot more with atrial ectopy. So if you see a patient with this much of an aneurysmal foramen ovale flap, I do give them at least the talk on frequency of atrial ectopy, and if abnormal beats or irregularity are heard, that wouldn't be a shock. It's very strongly associated with this. So back to ASDs, they're often seen in isolation, but are seen commonly with other complex CHD. 10 to 15% of secundum ASDs and 80 to 90% of sinus venosus or SVC defects are associated with partial anomalous pulmonary venous return. The primum spectrum or AVSD spectrum is the one you think of more likely to be associated with trisomy 21 and other aneuploidies, similar to seen with coarctation or other extracardiac disorders. The syndromic associations for isolated ASDs to remember is mostly Holt-Oram syndrome. Anybody have any ASD questions before we move on to the ventricles? Nope. Okay. VSDs are, I don't want to say the bane of my existence because I love finding them, but they're a lot more common than you ever thought you would find if you start to use all of the techniques that Elena mentioned and Tracy mentioned, and, using your angle of insonation to pick up flow across a ventricular septum and optimizing your color flows. And it's one of those things that you will learn to pick up and have a lot more confidence with. So it's a septal defect leading to some interventricular communication. It is isolated at least a third of the time. As far as CHD incidence goes. Another 30% of the time, and these are the more atypical VSDs, you're going to see in association with other forms of CHD. So perimembranous can be classified, as we see here, outlet, muscular, and these relate to size, to location. One of my biggest pet peeves with getting a report about a suspected VSD is where it says VSD. And I'm like, where, how big, location. So if nothing else, learn to be really precise. There is a 2 millimeter inlet VSD that extends anteriorly to X, or there is a mid-muscular VSD just above the moderator band. Like, learn to be really precise in your nomenclature of VSDs because they're very different in their significance. So a perimembranous VSD can be infracrystal or conoventricular, and you're going to see that in that outlet tract view kind of just below the aortic valve. I have one really preferred view to look at these, which I didn't happen onto until quite a few years after doing this, and it makes a lot of sense, so I'm going to impart my wisdom, such as it is. Outlet VSDs, muscular, are going to largely be seen in that 4-chamber view and are oftentimes multiple. And the inlet VSD, which we talked about, the posterior, is part of the AV septal type, where we mentioned this morning you have that lack of offset, and that's because of the lack of tethering. So again, a schematic: muscular VSDs, inlet VSD at the level of the 4-chamber view or the AV valves, outlet and perimembranous VSDs. Now, the definition, as we said, is defined by their location anatomically in the ventricular septum. Your ability to pick them up is very different. There's a real skew towards picking up the muscular ones fetally because they're simple and because they're largely picked up in the 4-chamber view. Neonatal cases predominate with the perimembranous defects, which are really trickier to pick up prenatally. So here's my little piece of wisdom I'm going to impart to you. I love the high short axis view for picking up these outlet VSDs. And it was kind of an earth-shattering experience for me when I realized that this part of the outlet septum really helps you pick up, especially like, how many of you have ever struggled with, I don't know if that's an aortic override, is that a VSD? Well, flip immediately to this view and you're going to get a lot of clarity as to whether you have an outlet VSD. But again, this is from a cardiac pathology atlas that's 40 years old, but really emphasizes that these perimembranous inlet, outlet, and subarterial defects are amenable to diagnosis in that high short axis view. So again, you've heard this a couple times this morning, but just for a little bit of added shock value, this is a heart facing downwards. Again, I have my color flow on. My box is of the correct size, my color parameters, wall filter, scale, etc. I see absolutely no VSD here at all, right? Why? Physics. I can't believe, I needed tutoring for MCAT physics, and here I am telling you all about it. I take this very same heart and turn it to the side, where now I've optimized my detection rate by looking for flow that is parallel to the angle of insonation, and all I've done is move my hand across mom's abdomen to get the apex of the heart to 9 o'clock. So here would be a mid-muscular ventricular septal defect seen in the level of the 4-chamber view. Now, inlet VSDs, as we mentioned earlier this morning, can immediately you can be tipped off by the lack of AV valve view. The other one, which is a little nuancy, is, I don't know if you're noticing right over here as we kind of pan in and out of the image, the tip of the ventricular septum over here, if there's a defect, tends to look a little brighter white and a little bit echogenic. And that's because the sound waves are hitting on the borders of the tissue. So if you see this be a little bright white, see a defect here with no offset, that should really prompt you to think this is a true finding and maybe not just that thin membranous area of the inlet septum. Again, turning my apex to the side, here's our inlet VSD, so bidirectional shunting just below the AV valves. Some of them are fortunately really obvious, but here you can see the tip of the ventricular septum has a little bit of a brighter white echogenic factor to it just based on refracting the sound waves off the defect, off the edges of the defect. So mid-muscular VSD, most common thing that I'm going to pick up prenatally in an otherwise normal heart. Just remember the physics of the machines and what you need to do to generate this image. And also remember that the ventricular septum is a three-dimensional structure. If all you are doing is imaging in that mid four-chamber view, you're not going to pick up the anterior ones and you're not going to pick up the posterior ones. So when you have that four-chamber view, up and down, up and down, up and down. The ones that are going to shock you, to be honest, are as you're coming up into that three-vessel view, outflow tract view is when you're going to hit that like anterior muscular VSD that didn't get picked up before. But this low short axis view, which is really just a completely perpendicular view to this, will give you some hint of where your defects are. Oftentimes they're multiple. I like this picture because it's got at least two of them, and I know this baby has three. But again, small color box, correct settings, trying to make this septum as horizontal as I can within the constructs of baby's position. Apical muscular VSD, notice how it's really only appearing as I come up into my outflow tract views. So that's a hint that it's probably more anterior or higher up in the ventricular septum than you would get in a standard four-chamber view. And here it is on a low short axis view. See how high this apical muscular defect is? If all you're doing is imaging through this level and not kind of panning back and forth, you're going to miss this one entirely. So pink line denoting where your standard midline or mid-level four-chamber view would be. And again, the benefit of the low short axis view is sometimes they're stacked, right? They're not necessarily multiple in a way that you can pick up at the four-chamber view, but they may be multiple at a very similar location, just more anteriorly and posteriorly. And just having a little fun with a stick. Here's our mid-muscular VSD, pulmonary artery, right ventricle, left ventricle. Now, we talk about these mostly being bidirectional due to essentially the equivalent pressures in the left and right ventricle. It's not an easy thing to do to eyeball it, but if you want to prove it to yourself, you can superimpose an M-mode line on a stick. And if you understand that between these two green lines is what we're restricting our view of the ventricular septum to be, you can see it's bidirectional red, blue, red, blue, red, blue. It's just that your eye tends to see the blue a little more preferentially. Moving on to subaortic or conoventricular VSDs. This one is tricky. Why is this tricky? Because there's a huge part of you that wants to write this VSD off of, oh, I think that's just part of the PA as it's coming out of the right ventricle. But how do you prove it? How do you know you're just not catching the bottom of the pulmonary artery instead of really seeing a bit of a conoventricular or subaortic VSD? Well, that's this high short axis view. Here's the subaortic VSD here in that view that I showed you in that little schematic before. There's a better view one later, but I'm going to save that for the associated abnormalities. So remember that VSDs are commonly associated with other complex CHDs. Some of them are plus minus, some of them are obligatory. I'll just save this chart for your reference because I know most of these disorders are going to get reviewed in other talks. Here's sort of your typical anterior malalignment VSD or aortic override. That would be a hallmark feature of tetralogy. So here we have our ventricular septum. The anterior border of the aorta is anterior malaligned, so the aorta overrides the two ventricles. This is another example of where I think you should start to make use of that high short axis view. This is a fetus with tetralogy of Fallot. Not such severe pulmonary stenosis, mind you, but a good depiction of how this view helps you. So normally your high short axis view, you have this sort of en face aorta entirely closed in, or a closed circle. With tetralogy of Fallot, you have the conal deviation, which is this aspect right here, into the infundibular area of the pulmonary artery, which narrows it. So that's how you get part of your pulmonary stenosis. And here's your VSD. So let's remove these cartoons. Notice how that view is immediately more reassuring to you, like, yep, that's truly a subaortic VSD. I'm not just catching the part of the pulmonary artery as it comes out of the ventricle. So that's why I loved that view and that schematic. And I think for me, it was a really nice way to be able to reassure myself about the presence or absence of a VSD. What about this one? This one's a little bit tough. This is a posterior malalignment VSD. So instead of the anterior border of the aorta overriding, it's essentially underriding. And this is really commonly associated with interrupted aortic arch. So here's our large pulmonary artery, small ascending aorta. And as you come up in and up of this heart, you'll see there's no transverse aortic arch. Again, another overriding or subaortic VSD, this one with deficiency of conal tissue. The echogenicity of the valve tells you that this is most likely to be a common arterial trunk. And finally, another weird one. This is a double inlet left ventricle. The communication between the larger left ventricle and the rudimentary right ventricle is called a bulboventricular foramen, but here you can see the shunting across that ventricular septal defect. So the things to remember, it's associated with many forms of complex CHD, but there will be a huge incidence in your patient population using correct ultrasound settings to find these as isolated muscular defects. They're the most common lesion by far seen in many chromosome disorders, and that's one thing to keep in mind, especially if it's not your standard run-of-the-mill mid-muscular VSD. When isolated, the aneuploides association is related to location. Mid-muscular, very low risk. Subaortic or malalignment type VSD, very high risk. And there's a likelihood of spontaneous closure, though if they're malaligned, they're not going to spontaneously close because there's no way for those edges to reapproximate themselves. So final comment is, just because this comes up a lot with patients, what is the risk of underlying genetic disorders with an isolated ventricular septal defect? Again, muscular are very common in fetal life just based on the ease of picking them up. Perimembranous a little bit less so, but the chromosomal anomalies are part of the perimembranous cohort, very, very low risk in an isolated muscular VSD. What do I do personally? I make sure they have a low risk NIPT. Ideally, because I'm a little bit of a worrywart, I try to make sure there's a 22q deletion included in that. But this perimembranous cohort is going to include all those babies, the inlet VSD of Down syndrome and other things that are a little bit more tricky from a genetic standpoint. Thank you all.